Headaches. People come to see us in the emergency department with headaches all the time. And when people come to see us in the emergency department with their headaches, they usually want to know two things. First of all, they want to make sure that this headache isn't going to kill them. And second of all, they want to feel better. There's really one big question when it comes to headaches in the emergency department, and that question is, are we going to take a picture of this person's brain? And for us, that usually means a CAT scan of the head. Obviously, we can't CAT scan everybody, so we need to figure out which patients we need to do neuroimaging on. But let's take a step back and talk about headaches. Headaches can be divided into two major classes, primary and secondary, each which then can be subdivided into many other different types of headaches. Another way we can categorize headaches is seen in this chart taken from Tintinelli's Emergency Medicine, which basically breaks headaches down into four different categories. The first category being headaches with a really dangerous etiology that we must find today so that we can do something about it emergently. The second category of headaches are headaches that have an important underlying cause, something that we do want to know and diagnose, but do not necessarily mean some sort of emergent identification and treatment today. The third category is secondary headaches that are not life-threatening, but do have some sort of reversible cause. It's important to find out these reversible causes because once we find them out, we can do something about it and make the patient feel better. And finally, the fourth category is the aforementioned primary headache syndromes. And that is where we're going to start today. Tension headaches. These headaches are by far the most common there is. 4 out of every 5 human beings will experience a tension headache at some point in time in their lifetime. It usually feels like a band, like squeezing around the entire head. And most people with tension headaches do not need to come to the emergency department, although some do. The first-line treatment for tension headaches are the usual suspects, good old NSAIDs and acetaminophen. Migraine headaches. Migraine headaches come in lots of different forms. Many of them have an aura that let the person know the headache's about to come on, but not all do. Classically, they're on one side of the head, but again, this is not true for all migraine headaches. Most people with migraines are throwing up, they have sensitivity to light. Many of them will know they have a history of migraines, or at the very least will know of family members who have had migraines before them. And as I mentioned, they come in lots of varieties. Some varieties even have associated neurologic-like symptoms, which can make a migraine headache be a stroke mimic. First-line treatment for migraine headaches, again, are NSAIDs and acetaminophen. However, most patients who come to the emergency department with migraine headaches have already tried these over-the-counter remedies. So what else is considered first-line treatment for migraine headaches? Well, the class of medications known as dopamine antagonists, the one which we use the most being metoclopramide, are known to be very effective for migraine headaches and can be given intravenously when your patient's vomiting. Triptans, the most popular being sumatriptan, are also a very effective medication for migraine. They can be given orally, but they can also be given in injectable sub-Q form and intranasally. The injectable or intranasal form may be preferable in the emergency department because of a quicker onset of action. Ergotamines are another class of medication which have been considered first-line agent for migraine headaches, but have a poor side effect profile, cause a lot of vomiting, and for that reason have fallen out of favor. The third type of primary headache is a cluster headache. Cluster headaches are more frequently in men, but not always. They tend to be episodic. They have a very quick onset of action and are often self-limited and go away pretty quickly as well. When they do come on, they're intense and very painful, often described as stabbing or like a hot poker behind the eye. Cluster headaches, when they come on, can often be traced back to some sort of trigger. And the triggers are our most common triggers for basically everything: alcohol, smoking, and emotional stress. There are some typical physical exam findings in cluster headache, and these include ptosis, miosis, lacrimation, and rhinorrhea, all on the ipsilateral side of the pain. First-line treatment for cluster headaches is oxygen. Oxygen therapy is thought to cause cerebral vasoconstriction. It's also thought to disinhibit axonal activity in the trigeminal nerve, which is where cluster headaches are thought to come from. Oxygen was first used for headaches in the 1940s. It became a popular treatment for cluster headaches in the 1980s, and over the past several years, there have been many trials showing the efficacy of oxygen in treatment of cluster headaches. The exact amount of oxygen is not known, but most places suggest somewhere between 7 to 12 liters per minute for anywhere from 15 to 20 minutes of high flow oxygen. Other than oxygen, triptan are again considered first-line treatment, and it's preferable to give this in injectable form if possible, because this is the fastest acting version of triptans. And cluster headaches, although self-limited, come on very quickly and are very intense. So you want something as fast acting as possible. Oxygen and injectable triptans are both very quick acting. Other than that, all of the same first-line agents that can be used for migraines can also be used for cluster headaches. That brings us to secondary causes of headaches, which is a much larger category of headaches. I've mentioned subarachnoid hemorrhage and meningitis specifically on this chart because these are two very dangerous etiologies of secondary headaches that we need to rule out in the emergency department. As I mentioned, there are many, many types of secondary headaches. In the International Headache Society's classification of secondary headaches, there are 8 subgroups alone, and under each of these 8 groups fall many different types of headaches. So we can't possibly talk about all the different secondary causes of headaches. This table, also taken from Tintinelli's Emergency Medicine, shows a list of common secondary causes of headaches and lists them according to critical causes and reversible causes. Now, if you look at this table, only a very small section of the table is neuroimaging helpful in the diagnosis. This helps to remind us that a good history is very important in the diagnosis of headaches because there are many dangerous headaches in which neuroimaging won't even help us with. One example of that is carbon monoxide poisoning. Carbon monoxide poisoning frequently presents as a headache, but you won't be able to get the diagnosis if you don't take a good history and you don't have it on your differential diagnosis. And like many of these other types of headaches, neuroimaging will not be helpful. So this brings us back to our original big question. Do I want to do any sort of neuroimaging on this patient? Well, there are many guidelines about neuroimaging and headaches, but not many that involve the emergency department. This one guideline from 2008 comes from ACEP. And in these guidelines, they ask the question, which patients require neuroimaging in the emergency department for diagnosis of their headaches? Well, there's very little evidence to help support these decisions. In fact, they were unable to make any level A recommendations about neuroimaging for headaches in the emergency department. They were able to make several level B recommendations, however. The first is a patient presenting with a headache that has some sort of new neurodeficit should get an emergent head CT. No argument here. The second recommendation is that those patients with new, sudden onset, severe headaches should also get emergent head CT imaging in the emergency department. Now, This obviously includes the classic thunderclap headache in subarachnoid hemorrhage. But studies have shown in the other more emergent etiologies of headaches, they frequently present in a severe fashion and in a sudden fashion. So whether you're looking for subarachnoid hemorrhage, a brain tumor with edema, or some sort of other bleeding, have a high suspicion in acute onset headaches that are severe in nature. And then finally, the third recommendation is about HIV positive patients. These patients who have a new type of headache should be considered for emergent head CT. Finally, there's a level C recommendation. This recommendation is for patients greater than 50 years of age with a new type of headache, but no new neurodeficits. These patients, they say, should be considered for urgent neuroimaging. Now, they define urgent neuroimaging as either imaging in the emergency department or imaging done on an outpatient basis in a very timely manner. Now, which patients in this group get CAT scans in the emergency department versus getting outpatient imaging is going to be determined based on your clinical suspicion as well as what type of outpatient follow-up these patients can get. So headaches. Remember, in the emergency department, we have two jobs. One is to find the life-threatening causes, and the second is to make patients feel better. Thank you.